we felt that we wanted to liven up things a little bit, although Mark couldn't have done a better job, but we also thought we'd get a bit of debate going. And when we were thinking about topics for the debate that were really pertinent to survivorship, changing the way that cancer follow-up is undertaken was pretty much at the top of the list. Now, there's a lot of talk these days about reducing unnecessary hospital visits. Possibly that's quite a good idea to make us more efficient and save some funding. And there's a lot of talk, which is very well meant, about patients looking after themselves and getting in touch when they've got a problem. Well, I think a number of you here will probably have some very mixed views on that, and I think more widely there are a number of different views, and so we thought this would be quite a good subject to focus on. And we've got two very brave clinicians who are going to put forward the arguments for change in practice or not. And we have Dr. Dorothy Goddard, who's a breast radiologist and lead for the NCSI Breast Cancer Pathway Developments, and Dr. Mike Leahy, who's a colleague and medical oncologist down the road at the Christie. And Mike is director of our teenage and young adult cancer services and also a sarcoma specialist. Now, I've asked them both to be provocative and to set the scene for an ongoing debate that I hope will involve all of you as we join discussion groups. And some of those themes are going to be fed into our panel session at the end of the morning. So the gauntlet that we've thrown down is a motion saying the proposal for self-managed follow-up is a dereliction of NHS responsibilities to patients with cancer. And because we're doing things a bit differently today, we're actually going to welcome Dorothy Goddard first to make the case for change, and then Mike is going to stand up and staunchly put the case against. So welcome, Dorothy. I might take the lectern.
Well, thank you very much for that introduction, Wendy, and thank you for inviting me to participate in this debate and to speak to you about something about which I feel very passionate. And as we were saying, we're going to break with convention, which after all is a lot about what I'm going to talk about, by having the motion opposed first. So, as Wendy said, proposals for self-managed follow-up are a dereliction of our NHS responsibilities to patients with cancer. And through this presentation, I'm going to be speaking against this motion. But first of all, I thought it was important we define what are our NHS responsibilities. What do we mean by patient empowerment and self-management? And then to describe the context of supported self-management and remote monitoring within the survivorship model. So how do we find out about our responsibilities? What are they? Well, we should go to the lovely NHS Constitution. And these are going to be all very familiar with you. But I just want to draw out one or two that are most pertinent to what we're talking about today. So the NHS aspires to the highest standards of excellence and professionalism in the provision of high-quality care that is, of course, safe, effective, and focused on patient experience. It aspires to put patients at the heart of everything it does. It should support individuals to promote and manage their own health. Services must reflect the needs and preferences of patients, families, and their carers. It should work across organisational boundaries in partnership with other organisations. And of course, it's committed to providing best value for taxpayers' money and provide sustainable use of, obviously, finite resources. And what about the other side of things? What is patient empowerment? How should we define that? Well, we should go and ask the people who went to the first European Congress on patient empowerment, held in 2012 in Copenhagen. This was organised by the World Health Organization and hosted by the Council of the European Union. And a commentator from that conference put together the following statement: patient empowerment through self-management is a process to help people gain control, which includes people taking the initiative, solving problems and making decisions, and can be applied to different settings in health and social care. And by learning to self-manage, people with chronic diseases, and of course that does include some people with cancer, are most likely to achieve better health outcomes, make best use of health systems, and remain integrated in society and also into the workforce. But does it work? And what is the evidence? The Health Foundation is an independent charity and dedicated to supporting healthcare improvement. And what they did was they did a review of the literature based on almost 600 studies published in the UK and internationally. And there certainly is evidence, actually a growing amount of it, that supporting self-management can improve people's quality of life, clinical outcomes, and the health service use. And certainly a sort of resounding conclusion from all of that review was that self-management works and the proactive strategies work best. And by proactive, they mean not just handing out information leaflets, by education and support, ongoing support. So let's put the context. Well, we're all aware about the increasing incidence rate of common cancers, particularly. And this graph shows the incidence increase from between 75 and 2011, male, female, and all persons. And we're aware of the factors for this. Lifestyle certainly has an influence, improved detection, and of course, our aging population. But the other side of the coin is that we're getting better at picking it up and dealing with it. And of course, the 10-year survival rates are very much different than they were at the beginning of this chart in the 1970s for most cancers. There are some, unfortunately, that are still along the bottom of that, but most have made a big difference. And certainly looking at breast cancer, for example, with 40% survival at 10 years in the 70s, now looking at over 80%. And no doubt, earlier detection with a greater proportion of an earlier stage of the disease from the outset has definitely played a part. But improvements in the quality and availability of increasingly effective treatments has a large part to play in that. So, what next? I survived my cancer. What happens to me now? Now, sadly, not everyone does survive cancer, but many people will live long and healthy lives following cancer. Some have a range of significant physical, psychological, or social needs following their cancer. They can be left with short or long-term consequences, not only of the cancer itself, but of the treatments. And then yet others live with chronic or incurable cancer for many years. So what about follow-up then? How are we going to best look after these? So when I talk about conventional follow-up, I'm talking about these regular visits usually into the local hospital and outpatient follow-ups. If you think about the numbers, so UK cancer prevalence in 2012 is just under 2 million. Worth noting, most of those were female, over 65, and actually a lot of cancer survivors are breast, 28% at that time. But the prediction is by 2030 there will be probably over 3.5 million. Interestingly, 41% of them will be breast cancer survivors, and a large proportion will be over 75. So clearly, it is absolutely unsustainable for us to deal with the standard conventional type follow-up for these numbers. And then to put some meat on this, the National Cancer Patient Experience Survey in 2010 certainly showed that there was a lot of unmet needs from that traditional model. Now, the health and well-being profile of some cancer survivors can be comparable to people with the chronic conditions such as diabetes or arthritis, in that there are some ongoing significant health and well-being issues attributed not only to the consequences of the cancer, but its treatment, as we said. Some examples there, 50% of patients after pelvic radiotherapy are left with bowel problems that are sufficient to affect the quality of life. 60% of childhood cancer survivors experience one or more late effects of treatment 10 years or more following treatment. And the conventional model of follow-up, although it can be really very reassuring at that moment, at that time for the patients, there was a very interesting article that I know many of you will be familiar here with, written by Arms et al., which started a lot of the debate, which really shed a light for the first time on these unmet needs. And this work showed that 30% of people after completion of treatment have 5 or more moderate or severe unmet needs, and this remains constant over 6 months. And so clearly, many of patients' needs are unmet by that model. Also, let's look at the evidence. What good is it doing at picking up recurrence? Routine follow-up appointments are not effective in terms of detection of recurrence. And certainly if we look at breast, which is my field of specialism, Breast cancer follow-up, there have been many studies, including a Cochrane review, and it demonstrated that conventional clinical follow-up was ineffective in detection of recurrence or improvement in survival. And so that publication there, the NICE guidance, there's sort of been several iterations of that, and it's gone from advising quite frequent follow-up to, oh, you only follow up for 3 years, to now they don't really mention traditional follow-up, but just talking now about the survivorship elements and the supportive care. And certainly there's great acknowledgement that recurrence of further disease presents outside routine appointments, of course, or detected, as far as breast is concerned, on surveillance mammogram. So if we are saying, well, this isn't so good and it's a lot of needs are unmet, is there a better way? It was to address these. The National Cancer Survivorship Initiative was set up. It was mentioned actually in the Cancer Reform Strategy of 2007. And through a partnership with Department of Health and Macmillan, supported by NHS Improvement, the mission statement, as it were, is written there. So the aim of this initiative is to ensure that those living with and beyond cancer get the care and support they need to lead as healthy and active a life as possible for as long as possible. And the next iteration of the NHS Cancer Plan, the so-called Improving Outcomes for Cancer, very definitely focused on outcomes and survivorship and a big emphasis on patient experience. So in recognition of the growing number of cancer survivors and many more people living with and beyond it, there was talk of sort of shifts really in how we approach this disease and condition. There must be a much greater focus on recovery, health and well-being after cancer treatment. We need to think much more holistically about our assessment, about our information and personal care planning. We should replace routine clinical follow-up with supported self-management. There should be much more tailored support and surveillance for the early recognition of further disease or post-treatment effects, in that the sooner you pick up those, the better able we are to deal with them. And again, the emphasis all throughout, a much greater emphasis on patient experience and outcomes, and we should be sort of routinely check on these to pick up for earlier problems. And the initiative actually looked at Cancer Pathway and broke it into key elements. Support through primary treatment from the point of diagnosis. Now, Mike mentioned that survivorship begins from the outset, and I couldn't agree with you more. Very definitely, survivorship does begin with lots of support right from that outset. But it's these three middle ones, the promoting recovery, sustaining recovery, and reducing the burden of consequences of treatment that we are particularly focusing on in this debate today. And of course, the latter one, or supporting patients with recurrent and active disease, is a return to much more sort of intervention, so we won't deal with that any further today. Promoting recovery, all patients are offered a tailored package of care, including a treatment summary, which should be just that, summary of the diagnosis and the treatment and the follow-up management plan, information about the side effects of the treatments and what to look out for further problems, key contact details. And this, remember, is not only for the patient, but for the GP. And certainly our GP colleagues do say again and again, what we need from you, rather than a long rambling letter, is actually some sort of key punchy points that will be most effective and helpful for us. And a care plan based on holistic needs assessment, a diagnosis, and on completion of acute treatment. And those are not only physical, lifestyle, but social, financial, occupational, psychological, and spiritual. There should be exercise programs. I'm sure that will be mentioned later today, how important exercise is in reducing the risks of recurrence even, and that's increasingly growing in evidence, certainly for breast. And all patients should be offered attendance at a health and well-being event program, where patients can have multi-professional advice, things like diet, exercise, but how to manage lymphedema, the perhaps menopausal effects of the treatments of breast cancer, for example. And certainly it's an opportunity for survivors to meet with professionals. At ours, we often have a question and answer panel with my consultant colleagues, and patients find that really, really helpful. But also just as important, we need to sustain that recovery. And if we're replacing routine clinical follow-up with supported self-management, we need to recognise it has to be for patients for whom this is suitable, of course, and because we're talking about discharge from clinical follow-up on completion of primary treatment. And this will vary from different types of cancer. But if you think about the pyramid there, and at the top band, Self-care with support and open access. That's actually suitable for most breast cancer survivors, roughly 80%. 50% of colorectal patients and 95% of testicular. The middle band shared care, there has to be a little bit more interface with sort of medical intervention, and the bottom one is complex cases will need some more hospital care. Sorry, thank you. Remote monitoring, of course, is very, very important, and that will need to have effective IT systems so that we can make sure these tests are done, the results are checked, and the patient and the GP is informed. There needs to be also lots of measurement of the routine outcome measures, just to pick up on any unmet needs. Of course, it's important to know how to re-access that service if there's a problem, and we need, as I said, to educate the people about what to look out for in terms of picking up any long-term consequences of treatment. The sooner we know about it, the sooner we can do something about it. So just finally, have a think about this new, perhaps non-conventional way of follow-up and these NHS responsibilities. So that first one, NHS aspires to the highest standards of excellence and professionalism in the provision of high-quality care that's safe, effective, and focused on patient experience. So let's have a look at how safe it is. In Bath, we've been doing this since, for over a decade, 2003. No routine follow-up since 2003. We've always provided open access with rapid return either via the cancer nurse specialist or a family doctor, and regular questionnaires gone through with the radiographer at the time of their checked mammograms. More recently, we've introduced the other aspects, moving on programs, holistic needs assessments and treatment summaries. And as regards safety, rates of recurrence have not been increased compared with the rest of England. Our survival rates are, in fact, higher than average. I know that's not just about follow-up, but it's certainly showing that our way of following for, as I've said, over a decade has not compromised our patients. And the regular patient experience surveys show a very high rating as excellent or very good. And that's for questions on aftercare. I am going to run out of time, so I won't say very much about this, but the survivorship was introduced at several pilot sites up and down the land, and an Ipsos Mori service evaluation showed those same sort of assurances, really. The next, the responsibility, it aspires to put patients at the heart of everything it does. It should support individuals to promote and manage their own health. Well, surely that is a definition of survivorship. And it works across organisational boundaries. Oh, yes, it does. Survivorship works across primary and secondary care, involves rehabilitation services which work obviously across health communities and with some cancer-specific specialist services. And about the sustainability and having good use of taxpayers' money, well, if you can read that yourself, savings and costs, there are fewer patients requiring routine follow-up. Remote monitoring will need some investment. There's better ambulatory care and less acute admissions, and they cost a lot of money, so there are definitely savings. And so long as we remember that this isn't all about saving money, it's just moving money around so that we can use it better to improve the quality of our patients, survivors' lives. And even NICE produced a quality and productivity study where they said that they thought the case was proven, that it certainly led to improvements in quality and productivity. So then, proposals for self-managed follow-up are a dereliction of NHS responsibility to patients with cancer. No, they will be met and shared with patients, and patients are empowered through supported self-management and remote monitoring within the cancer survivorship model, with improvements in quality and productivity. So, ladies and gentlemen, I think this motion should be opposed. Indeed, I'd go so far to say not to propose supported self-managed follow-up would be a dereliction of NHS responsibilities. So that's it. Thank you very much for listening.
Well done, thank you. Well, a lot of good arguments there. Let's hear what our colleague Dr. Leahy has to say about some of them.
Well, thank you very much indeed for inviting me to speak at this conference. And I'd like to thank Wendy and thank you for your attention. And thank Dorothy for her very interesting and witty and valid arguments. I'm a medical oncologist at the Christie Hospital, so I am a fully committed cancer clinician. And I have to declare some conflicting interests here. I am guilty of follow-up. In fact, I think I am seen as one of the clinicians at Christie that seems to do a lot of follow-up. In my team, we see probably 75 patient reviews a week, and only 5 of those patients are new patients. And sometimes the managers come to me and they say, Dr. Leahy, why is your new patient to follow-up ratio so high? And I think this is where this idea of self-managed follow-up has come from. And so my role today is to, I think, voice the unsayable things about the political correctness of self-managed follow-up. And I feel a bit like Nigel Farage here. Because I'm going to give voice to some of the things that I know some of you are thinking but would never dare to admit. So let's have a look at Dorothy's arguments. What she said is basically that there is a large unmet need in the aftercare of patients following cancer treatment. And secondly, that traditional follow-up is not meeting those needs. And I would agree with both of those statements completely. But unfortunately, those arguments are not arguments in favour of abandoning traditional follow-up in favour of self-managed care. And self-managed care is the training of patients to do their own follow-up and discharge from the clinic. And this is where the difficulty lies. I think we need to review the evidence that Dorothy has presented. And I think, unfortunately, there are some fallacious arguments here. First of all, this alarming story of the epidemic of patients that are going to be coming into cancer services, the increasing incidence and prevalence of cancer, and how we're going to deal with it, and the only way is to start discharging patients more to self-managed care. Who are these extra patients? Yes, there will be an increase in the number of new cancer diagnoses per year, but this is not, to a large extent, not due to age-specific increase in incidence. It's due to the aging population. And the problems of 70, 80, 90-year-old patients with cancer are quite different to the problems of 30, 40, 50, 60-year-old patients with cancer, and their requirements for follow-up are quite different. The second increase in prevalence is due to improved survival rates, cure rates, and secondly, the improvement in non-curative treatment at extending life. Well, the first, yes, you may say that those patients will be coming into our follow-up programs, but the other patients who are living with cancer, these are not candidates for managed self-care discharge from oncology clinics. Those are patients who we're going to be managing as an ongoing thing during their treatment. So I don't think that there is going to be a huge increase in the number of well patients suitable for self-managed care. The second fallacious argument is that there is a pot of gold that can be used to change our follow-up protocols and produce self-managed follow-up. And the documentation, some of which Dorothy has presented, give figures like 2.4 million follow-up appointments in medical oncology and clinical oncology per year, which translates to a pot of gold of £2.5 billion. Great! So if we can get rid of all of those follow-up appointments and have all this money to spend on self-managed care. Unfortunately, that calculation is based on that previous misunderstanding of what a follow-up appointment is. I'm seeing 75 patients a week and only 5 of them are new, but these aren't 70 follow-up appointments of well patients who could be discharged, who have no evidence of cancer and could be managing themselves in outpatients. So I don't think that that pot of gold is nearly as big as it could be. All of the arguments, in fact, based on these costs are, in fact, inadmissible evidence in this debate, because they're all based on the Alice in Wonderland world of NHS finances, which is based on tariffs that have absolutely no meaning at all compared to the services that are provided. So really, any argument based on costs using the existing tariffs is not admissible, because if we're going to break the mould, then we can't rely on the mould as arguments against what we're doing. Dorothy glossed very quickly over the evidence that self-managed care is actually effective. And she presented a statement that systemic reviews of the previously tried self-managed care programs had shown that they were better. Actually, that's not true. The British Cancer Survivors Study, which was a systemic review of a large number of reports in the literature, in fact concluded that there was very weak evidence that these programs were any better than traditional follow-up. So I think there is a problem there with the evidence. And the difficulty that we have with the evidence is that, of course, you can only retrospectively examine what the existing follow-up arrangements have done compared to small projects which are doing something different. And what nobody has tried to do really is to discharge patients from care and look at what their survival rates would be or the pickup of recurrence would be. So although it is true, apparently, that routine follow-up of breast cancer and testicular cancer does not routinely pick up that many recurrences, nobody has done the clinical experiment when those patients are discharged and then wait to see what happens. And patients who are involved in a traditional follow-up program, yes, of course, their recurrence may not be picked up at the moment they come in to see the doctor, but that is an ongoing package of care which those patients are participating in, which gives them the opportunity to come back to the hospital easily and if they have concerns, which is quite right, where most of the relapses are picked up. So, what I'm going to say now, I think, is coming straight to the elephant in the room here. The emperor has new clothes, and he is naked. What we are being asked to contemplate here with self-managed care is thinly disguised discharge from cancer care for a large number of patients. And the pyramid that Dorothy shows this large group of patients who can be taken out of oncology care and discharged, having had some patient education and an IT package that allows them to report their symptoms if they get unwell. IT infrastructure, by the way, that doesn't exist. So I think it is a dereliction of the oncologist's responsibility of care, and I'll up the ante a little bit for Dorothy here, because obviously the NHS would be taking care of the patients even in self-managed care, but I think it is a dereliction of the oncologist's responsibility of care to discharge their patients without proper follow-up after the end of treatment. Now, that's not to say that our normal traditional follow-up couldn't be improved. I absolutely agree with that. As the director of the Young Oncology Unit at the Christie Hospital, I am fully committed to the survivorship issues. And I know that there is a huge unmet need and plenty of opportunities for us to do better in our follow-up appointments, and an enormous opportunity for much more patient empowerment. But this has to be as an adjunct to and not as an alternative to continued follow-up in those clinics. The unwelcome truth, I believe, is that traditional follow-up, which is specialist supervised, not patient self-managed, remains the most cost-efficient way of giving aftercare for patients after a cancer diagnosis. So while there may be many opportunities for us to improve that traditional care, replacing it with self-managed follow-up would be a dereliction not only of our responsibilities to the patient, but also our responsibility to provide cost-efficient care. For the vast majority of patients, self-managed follow-up is beyond the resources of the NHS to deliver. We haven't talked at all about what it would actually take to produce these expert patients, but it's extremely time-consuming. And the amount of leeway that you would get from the small number of follow-up appointments withdrawn does not give you the opportunity to provide that kind of intensive patient education that would be required. Self-managed follow-up is appropriate for a small minority of patients who are clinically cancer-free at the end of their treatment, self-motivated, in good general health, well-educated, young, at least at heart, and affluent. And my suggestion to you is that there is a strong political motivation for what we are seeing here today. The introduction of self-managed follow-up is concurrent with other government initiatives which are designed to appeal to the Conservative constituency by appearing to reduce public expenditure on the others, the non-Conservative voters, the poor, the elderly, the disadvantaged. And this has been dreamt up in the corridors of Westminster by the lackeys and wonks of a morally bereft government, and has been sold and peddled with a sugar coating of political correctness about patient empowerment on the basis of weak or non-existent evidence. And I would strongly advise you to reject the proposal to introduce self-managed follow-up and to support the motion that proposals are a dereliction of NHS responsibility to our patients. Thank you very much.